All right, everyone, we're about ready. So on the stage today, we have an amazing panel of local oncologists who are going to give us an overview of the major organs affected by breast cancer. Their presentations will focus on research progress, what's happening now in these fields, and what we can expect to see on the horizon. So please refer to your folders for presenter bios and hold your questions to the end. We're going to let them each speak for a few minutes about each target organ, which you can see up here. And then we're going to ask them questions and have a nice panel discussion at the end of the panel. So please join me in welcoming Dr. Wade Smith from City of Hope, Orange County. Dr. Jose Carillo from St. Jude Medical Center. He's going to talk about brain metastasis. Dr. Ronald Tang from Breastlink will talk about lung metastasis. And then our own local from UCI, Dr. Farshid Dayyani, who's going to talk about liver and visceral metastasis. Okay, but before we get started, we're going to show a little short video about bone metastasis that was actually generated from our national office, and then we'll go ahead and get started.
Hello, I am Dr. Carlos Arteaga and serve as Director of the Harold C. Simmons Comprehensive Cancer Center at UT Southwestern Medical Center and the Associate Dean of Oncology Programs in Dallas, Texas. I'm also a member of the Susan G. Komen Scientific Advisory Board. As a medical oncologist, I see many patients with breast cancer, some with early stage disease and others with metastatic breast cancer. Our goal is to treat the breast cancers to extend and save lives. That's why you come to us and what you want us to do. We're so focused on treating the tumor that sometimes things like bone protection may not be top of mind. People with metastatic breast cancer in the bone are at risk of bone complications and skeletal-related events, which are also known as SREs. SREs include broken bones and spinal cord compression. Broken bones may need surgery to prevent or repair bones or radiation therapy to control bone pain. Spinal cord compression puts pressure on the spinal cord, which can cause pain and interfere with bladder and bowel control and also leg motion. As you can imagine, SREs can lead to quality of life issues like chronic pain and the potential loss of mobility, which make it hard to work and go out with friends or family. If you have one SRE, you are at a higher risk of having others. Survival is worse for those who have had an SRE than those without any. There are ways to help prevent and manage SREs. Bone strengthening therapy is a standard part of treatment for bone metastases. There are two types of drugs to help strengthen bones: bisphosphonates and rank ligand inhibitors. Bisphosphonates are zoledronic acid and pamidronate, which go by the names Zometa and Aridia, respectively. The second type of drugs are rank ligand inhibitors, denosumab, also called Xgeva. Use of one of these drugs can lower the risk of fractures, help reduce pain caused by bone metastases, and reduce the need for radiation therapy or surgery related to bone fractures and bone pain. One study showed up to 70% of women with bone metastases will have an SRE within 2 years of diagnosis without a bone strengthening treatment. If you have metastatic breast cancer in the bone and you're not already on a bone strengthening therapy, talk with your doctor. Your doctor can help you decide which bone strengthening drug is best for you. Your doctor can also talk with you about exercises you can do to help strengthen your bones, or exercises to avoid. If there are any dietary guidelines you should follow while on this treatment, and other ways you can protect your bones from fractures and other problems. You and your doctor can also discuss whether any of the medications you're currently taking, prescription or over-the-counter, affect bone health. Let your doctor know about any new symptoms. Sharing your concerns and asking questions can help us provide the best care for you. Thank you for watching. To learn more about bone strengthening therapy, visit the Managing Side Effects and Supportive Care for Metastatic Breast Cancer page in the About Breast Cancer section of Komen.org.
That was great. I'm glad we got that one, got that one to go. That was very nicely done. If you have any questions about the video, we can discuss that at the end of the panel session. But in the meantime, let's get Dr. Smith up here from City of Hope to give us a little bit more information.
Everyone can hear me now? Great. Okay, that video was a nice segue. I'm covering the topic of bone metastasis in breast cancer. I'm a breast cancer-focused medical oncologist with City of Hope, Orange County. And so, obviously, as the video points out, bone metastases we see in 70% of patients who go on to develop metastatic breast cancer. So again, as a whole, women diagnosed with breast cancer, about 30% of them, even though 90% are diagnosed with early stage, up to 30% of them can develop metastatic recurrence. And of those patients, 70% will experience bone metastases in their lifetime. So, you know, I just want to kind of equip everybody with some terminology because as I see it, you know, when I have patients come into my office and talk with me, they'll oftentimes be with a caregiver, a friend, and I always encourage that. And I think it's important for the patient and friend or caregiver alike to kind of know what to think about, know what to ask. You know, we're never put off by asking us questions. What about this? What about that? You know, because in the course of a patient's care, situations can change. Something we might not have considered earlier, maybe we consider now. And to be kind of a proactive catalyst, you help to move that ball forward. And so, in terms of terminology, we talk about bone metastases. They can fall into the category of lytic. Think of it as cancer cells punching a hole in the bone. Blastic, cancer cells that are laying down more bone and creating a thickened bone tumor, or a mixed picture where even within one patient, they can have some lesions that are, you know, punched out holes in their bones, and others where they have these blastic, solid bone lesions. And in terms of cancer subtypes, you know, prostate cancer classically falls into the blastic. You know, multiple myeloma and others classically fall into the lytic. But breast cancer, as well as lung, can kind of fall into this mixed blastic and lytic. And this actually can play into how we treat these tumors down the road. And so here you can see a classic blastic lesion right here. And whereas here you can see the lucency or able to see the darkening representing a lytic lesion there. And so important terminology to note because, again, when we scan the whole body, you know, here, for instance, is a breast cancer patient. She has blastic tumor. And here is a multiple myeloma patient that has a lytic tumor. Here is another breast cancer patient that has a combination of both blastic and lytic. Now, most patients with breast cancer, 60% of them will have lytic. About 20% will have blastic, and 20% will have a combination of both. And so when we talk about treating patients, for the most part, we treat it all the same. This is a patient that has cancer spread to the bone, and so these are our priorities. Heading off complications. And complications such as pain, complications such as diminished activity, able to get around, as well as inhibiting quality of life. And we can kind of compartmentalize all of these into what the video had mentioned, skeletal-related events, or SREs. And so basically when we do clinical research, we look for these SREs as endpoints to determine efficacy of a treatment. So a skeletal-related event might be need for radiation or surgery. It could be a tumor-related fracture. It could be a spinal cord compression. It could be a high calcium level, which is an emergency in the area of cancer. We need to bring that calcium level down emergently. And so when we talk about treatment, we include that within treatments directed against the cancer itself. And you know, the majority of late-breaking research that we're seeing in the past year kind of falls into this category. The best way to prevent bone recurrence and to treat bone recurrence is treating the whole patient, the whole cancer, as well as the osteoclast inhibitors, which are like the medicines that are pointed out, the bisphosphonates, as well as another category, rank ligand inhibitor for the drug denosumab. And then surgical intervention, which we try to avoid, radiation therapy, which we try to avoid when we can, and of course pain management, which is, I think, a very important category. And as I mentioned, 70% of patients with metastatic breast cancer will experience bone metastases, and this can be a large contributor to pain in that patient's lifetime. So, and then briefly, how does this happen? We know that circulating cancer cells enter the bone marrow compartment, and then they adapt to the bone marrow microenvironment. They are able to evade the immune system, remaining quiescent for a prolonged period of time, until such time that they emerge from their dormant state, they start to proliferate, and tumor deposits occur, still too small to be seen on a scan. And then once they've really manipulated the microenvironment, then we see the flourishing of these tumors to the point we can see them on scan. So here, again, breast cancer cells that enter the bone marrow space. And normal bone remodeling, you have osteoblasts that lay down bone and then osteoclasts that resorb the bone. And this is a continuous cycle. And even these cells kind of play into each other with these molecules, rank ligand and rank, to kind of keep the bone remodeled and keep the bone healthy. Cancer cells come in and disrupt all that. And they seem to have this preferential activation for the osteoclasts, particularly in osteolytic breast cancer. And they can basically kind of commandeer the machinery of the bone to help induce the cancer cell for the cancer to proliferate. And so really the whole strategy of giving drugs is interjecting molecules to trip up this means of interaction. So for instance, bisphosphonates, like the zoledronic acid that you saw mentioned, that little red molecule gets into the osteoclast itself. Again, the osteoclast is what breaks down bone and basically causes that cell to apoptose or destroy itself. And then the denosumab molecule, which is the rank ligand inhibitor, inhibits this molecule from activating and maturing the osteoclast. And so that's how these two categories of medicine work. And so again, these two categories of medicine, you have denosumab, you have zoledronic acid as the one we use most often. And the denosumab is given as a monthly injection. Side effects, infection, it can drop the blood calcium too low. It can also cause osteonecrosis to the jaw, I'll mention. And then the zoledronic acid is given as an IV infusion. It's given monthly or every 3 months. And patients can develop flu-like symptoms, which can be pretty profound, as well as having the risk of osteonecrosis, lower calcium level, and we have to watch their kidney function. So which is better? I prefer denosumab based upon 3 large studies, which again show a benefit in terms of delaying the timing of the first skeletal-related event, 26.6 months versus 19.4 months. And as well, another indicator, it reduces that risk overall by 17%. But keep in mind, there was no difference in survival for all of these. So osteonecrosis of the jaw, we can see in both, so we just have to be mindful of both. The denosumab may have a little bit of a higher risk than the zoledronic acid. And again, this is really the result of that remodeling of the bone, unable to maintain normal, healthy bone within the mandible, and then it's a setup for infection and dying off of the bone. And there are ways to prevent that. So again, giving medicines helps to prevent surgical intervention, but on occasion we do need surgical intervention. Just again to reiterate the 2 main types of surgical intervention, you can either do injection of cement into the collapsed vertebra in the form of either what we call kyphoplasty or vertebroplasty, or stabilization surgery. And so here's an example of vertebroplasty. You insert a needle, you expand that vertebral body with cement, and it's able to provide fairly abrupt relief of pain. The kyphoplasty is where these tamps or balloons are inserted in, expand the bone, and then after that, injecting cement into it. And again, I've seen profound, abrupt control of pain. So even though there's not a lot of large studies to validate it, in clinical practice, we use it quite a bit. The other surgical intervention we need to keep in mind is preventing fractures. And so we have a whole scoring system based upon tumors within the long bone, particularly the weight-bearing bones, what their likelihood of fracture is. And so this is, again, if you're accompanying a patient to a doctor's visit and we're treating and there's areas of bone. It's a good question to ask. What's the risk of fracture? Should this patient be benefited by seeing a surgeon? And we can see that certainly when this risk is high enough, and there's a way to score it, then we can see that we can reduce the complication of fracture considerably. And so it is definitely worth evaluating for that. Aside from surgery, there's radiation. Radiation can either be given in standard fashion or as a means of radiosurgery where you can target the tumor itself, avoid the healthy bone, and it's, again, what we call stereotactic radiosurgery if we're talking about the brain, or SBRT if we're talking about the rest of the body. And it's, again, something that we're using more and more. So it's a way of delivering treatment, controlling bone disease, and in some cases avoiding surgery. And so it's, the long and short of it is, when we see tumor that involves the bone, it really does require a team approach. Having the radiation doctor involved, having the surgeon involved, and of course the medical oncologist involved, because it is a constantly, the needle is constantly moving in terms of how we address these. And I've talked about stereotactic body radiosurgery as being this benefit. We do watch for certain complications such as flare causing pain, and that can be treated with steroids. And then just to touch upon systemic medicines, and I can talk about this afterwards too. You know, we've to some extent followed the WHO ladder of the WHO ladder of pain medicines. And typically we start with the non-opioids, and then as we get to mild to moderate, we might consider one of the short-acting opioids, and then as we get to moderate to severe, some of the stronger opioids, plus long-acting opioids. And so, but again, there are certain medicines that can be given aside from opioids. And again, an important question to raise with your doctor, you know, are we optimizing pain control by considering, for instance, the bisphosphonates, the anti-resorptive bone agents? Those have a direct effect on controlling pain. Steroids can also reduce pain and should not be overlooked, as well as radiopharmaceuticals, question mark. Again, if it's a blastic tumor, we think that these tumors benefit by giving kind of a whole body radiation dose for patients that have a good life expectancy. So that should be considered. As well as there's these other kind of non-traditional medicines that can also be looked at, all with varying degrees of validation. And so, you know, I can be reached and talked about that later as well. And of course, there's other means of interventional pain control that can involve, you know, severing a nerve, disrupting a nerve that can control pain in some instances of spinal involvement. So I thank you again for having me here.
Great, thank you so much. That was very informative. Our next speaker is Dr. Carillo, who's going to tell us a little bit about, which side are you doing? Brain metastasis.
Great. Great. Thank you. My name is Jose Carillo. I'm a neuro-oncologist, and I am at a number of different sites. I like to drive, I guess, a lot because I'm at Hoag Irvine, I'm at St. Jude in Fullerton, I'm at St. John's and John Wayne Cancer Institute over in Santa Monica, quite a bit. And so we can go through next slide here. But as a neuro-oncologist, I primarily specialize in brain and spine tumors, and those can be of the brain directly, or as I'm going to talk to you about, metastatic from other organs, and specifically we'll talk about breast cancer and metastases to the brain. So next slide. Oh, I've got the pointer. That's me. Okay. All right. So we'll identify some symptoms of brain metastases and multiple treatment options. In the time permitted, of course, it's not going to be as comprehensive as I would like, but I do want to point out a few trends here which are concerning. So there's estimated 150 to 200,000 cases per year of brain metastases, and an estimated 70,000 new brain metastases over the lifetime of patients. This is older data. I think it's increased nowadays as patients are living longer, which is great, but some of the long-term distant metastases like to the brain are being seen more often. And brain metastases can be seen in up to 40% of cancer patients in general. Within breast cancer, this is about 15 to 20%. And so a little bit less. I've thrown in lung and melanoma as references of other cancers that often like to seed the brain. I know I'm supposed to be pointing it somewhere. Screen? Okay. All right, screen it is. And here's a incidence here that also shows that trend. I'm just clicking away. There we go. So how do we diagnose brain metastases? MRI is really the imaging modality of choice. CT scans can show an indication that there may be something there, but really MRI is what visualizes this the best. Here are a couple of patient MRIs with metastases in the posterior part of the brain called the cerebellum. Here in the cerebellum there, the arrow actually, I think, didn't really translate out. It's a little bit low on the images on my screen. It's a little bit more direct. This area of the brain is one of the more common sites for breast metastases. Of course, they can go anywhere in the brain. The location and size of which is really important in determining some of the initial treatments and even initial diagnoses. As is the case, sometimes the brain metastases can even be the initial presentation of the breast cancer. And so sometimes the brain surgery that might be there to relieve pressure and compression of the brain might also yield the initial diagnosis of that. And so surgery is a long-standing treatment for brain metastases. It can be very helpful, especially when it's metastases that is large and shows a lot of swelling. In this case, I wanted to kind of highlight that I'm showing you brain metastases that are within the brain and also something called leptomeningeal brain metastases that are along the covering of the brain. Less common, thankfully, as they are more aggressive and denote a more aggressive and less favorable prognosis. So what are some signs and symptoms? And I show this screen just to kind of raise awareness because these may be some of the symptoms that are more indicative of brain metastases. Headaches can be seen in 40 to 50%. Of course, people get headaches. Tension-type headaches are common, but I'd say that headaches that are out of the usual severity, frequency, headaches that are not going away with the sort of usual treatments, whether that be Tylenol, acetaminophen, ibuprofen, whatever your standard treatment is, or headaches that are just new if you're not a headache sufferer. Focal weakness, arm weakness, leg weakness, these things, facial weakness, these are things to pay attention to. Mental or behavioral disturbances, sort of personality changes can be a diagnosis and a clue. Difficulty with walking and seizures, so convulsions can be seen up to a quarter of symptoms. So these are things to look for as far as signs, things that may be picked up at an examination by a physician: cognitive impairment, weakness, sensation changes like numbness, imbalance, speech changes, visual changes, and visual acuity changes are things that should be looked at. So understanding the biology is crucial, and this is where the research is so important. I'd like to thank Dr. Soloff for a great talk at the beginning. It was really interesting, and these are the directions. Picking an area that the cancer utilizes and trying to block it, and that's the heart of what is important. In looking at the treatments for brain metastases, radiation and surgery are sort of the hallmarks of treatment for multiple brain metastases, and multiple is kind of a number that is variable. Whole brain radiation has been the standard of care, and over 200,000 people per year will receive whole brain radiation. There's a study using memantine, which is an NMDA blocker, to decrease some of the neurocognitive effects that it may have on thinking and memory. And so that is something that has been added. For a small number or very focused number of brain metastases, stereotactic radiosurgery is important. You may be more familiar with that by names such as CyberKnife, Gamma Knife, Novalis, TrueBeam. These are brand names of this technique. So the technique is what's important, but I throw those out there because that may be what you have heard. There's newer research looking at avoiding key structures in the brain, namely the hippocampus. This is a center for memory, especially short-term memory in the brain. And so avoiding this area while still targeting the whole brain, the subject of a phase 3 trial, they paired that with memantine to see if that could also generate the protection, but had that avoidance of the hippocampus in both arms. They did battery of neurocognitive testing, which typically takes about 2 hours. So these were thoroughly investigated and saw the risk of cognitive failure was less in those that had avoidance of the hippocampus. Immunotherapies are important, and this has been kind of talked about in other cancers, but I think the pairing of immunotherapies with focal radiation, stereotactic radiosurgery, is important. And this slide kind of talks a little bit about the timing of which immunotherapies with focused stereotactic radiation done before or done after that radiation. And it really looks like a lot of the benefit is doing it either combined with or with that type of stereotactic radiation before. And so I've circled kind of the curves that highlight some of the benefits when pairing radiation and immunotherapies. These are some other targeted therapies. We talk about other targets, especially with HER2 positive cancer and looking at the brain metastases. And so I wanted to kind of show some of the responses that we can see. These are a little bit higher in people who have not had prior radiation, but the clinical benefit is variable. Getting a lot of these drugs into the brain is somewhat difficult, even in medications like everolimus that we know can get in. Response rates have been very modest. So we keep looking. This is a study with neratinib and capecitabine in HER2 positive breast cancer with brain mets, showing patients, and most of these after radiation or surgery, so representing real life scenarios with oral neratinib and capecitabine. And they had 2 cohorts, one that had not received lapatinib before, that's cohort 3A, and those that had been previously treated. And they did have very good response rates, up to almost 50% in those who had not been previously treated with lapatinib, which can also target this targeted pathway. But there was responses seen in both arms. So this gives us some hope for targeted therapies. This is a study, ANG 1005, which modified existing chemotherapy paclitaxel to help with transport into cancer cells and avoid export out of the cancer cells. I think that this was interesting because the response rate within the central nervous system was high at 71%. In typically excluded patients, leptomeningeal patients, they actually had high response rates. These are typically cancer spread within the spinal fluid that is very resistant to oral and IV medications. And so I think this is an important area to look at. Importantly, also extracranial, meaning body control, was 90%. And this is a study that is actually going to be starting up looking just at those leptomeningeal patients for HER2 negative. And so I'm happy to be one of the investigators on that trial. So in summary, I think the incidence of brain metastases disease, unfortunately, is rising, and we need to be aware of that. This is an unmet clinical need. I think we're going to be seeing more brain metastases, unfortunately. I also want to let you know there's life after diagnosis of brain metastases. I think historically, brain metastases, unfortunately, has been synonymous with sort of end of treatment options, but I think that is changing. There are new chemotherapy agents that show promising results in brain metastases. And furthermore, clinical trials exist in these patients that historically have been excluded. So I'd like to thank you for inviting me. I'd like to thank the study sponsors. Thank you.
Thank you so much. Well, as we all know, this is a very terrifying form of the disease, but it's great to hear about new progress being made. Next, we have Dr. Tang, who's going to tell us a little bit about lung metastasis.
Thank you. Thank you so much. Thank you for the Komen Foundation for inviting me today. So I'm going to be talking about breast cancer metastatic to the lung. Couple things. I'm a medical oncologist, so I'm not a cardiothoracic surgeon or a pulmonologist, but I'm a general medical oncologist. We have about 8 or 9 clinics throughout Southern California, and most recently we are joined with Breastlink. So I treat all different types of cancers, but I would say a majority, 30% is still, I treat breast cancer, and about 10 to 15% of my patients are metastatic. So let's talk about breast cancer to the lung. So a quick overview, I'm going to just talk about some quick risk factors for which patients can metastasize to the lung. We'll talk about, a little bit about anatomy. There's different scenarios and different types of quote-unquote lung metastases. We'll talk about some symptom management, and last we'll talk briefly about some clinical trials that our practice is involved in. So a quick little introduction here. This I got from Scientific America back in 2005. It was one of the landmark kind of first public kind of descriptions of what happens to our chromosomes in cancer. So on the panel, you see the normal cell, nice looking little chromosomes. There's about 23 pairs there. That's what we all have. And then you see the tumor cell there. Everything is kind of distorted. Some have 3 chromosomes, like chromosome number 2 is completely missing. So that's what's happening in the cancer cell, and that's what's happening to patients who are progressing through cancer. And that is showing the challenge of what, as everybody here on the panel is dealing with at this point in time. This interesting thing, here's a quick, it's called a model for breast cancer development over molecular time. Quick little kind of summary is that when you look at the top, that's where normal mammary epithelial cell development is. And as time goes through, you have your first mutation, and as you get towards down to the bottom, that's how much tumor burden or clones of cancer you have. So at the bottom portion, when we first diagnose a patient with cancer, that's how many mutational clones there are, okay? So when we're diagnosing patients with cancer, the challenge with us as a medical oncologist is that we're dealing with multiple large amount of clones already, not just one. So that's the challenge at this point in time. So who's at risk for a lung met? So a study was shown that about 23% of women who have stage 4 cancer have lung metastases. It's the second most common behind bone. And the patients who are at most risk are obviously your triple negative and HER2 amplified patients. And then hormone positive patients are the least aggressive. So usually, unfortunately, when you have lung metastases, overall survival in the study is about 23 months. And we're hoping to increase that, obviously. So quickly, the anatomy of the lung. So the right lung has 3 lobes and the left lung has 2 lobes. But the key thing is you can get a metastatic lesion within any area of the lobe. But also most of the time, a lot of patients who complain of shortness of breath and cough have fluid already. That's called a pleural effusion. And that's located, you can develop a pleural effusion in the pleura, which is the soft tissue that's covering the lung. So that's what I'm going to be focusing on as well. So here are the different scenarios for lung metastasis. A patient can have 1 single solitary metastasis in the lung. They could have a pleural effusion, which has cancer cells. The third and fourth are your kind of most aggressive metastatic areas to the lung, where you get pleural carcinomatosis, where it's basically a complete studding of the lung with multiple small little tumor cells. And then you have lymphangitic spread, which is the most aggressive and most symptomatic, where basically the cancer is spreading throughout the lung lymph area, and that's the hardest scenario to treat for us medical oncologists. So this is a picture of a single solitary met that you see there, that white spot there. When we see that, obviously, unfortunately, it is still considered stage 4 breast cancer, but Most recently, and we get this data from our colon cancer patients, is that we used to not operate on these. We used to just give chemotherapy, systemic chemotherapy, and would hope for these things to shrink. However, we've realized that even with the systemic chemotherapy, we cannot bring these things down to zero. So if a patient has one solitary lesion, there's been studies where you can go and resect these single solitary lung mets that our cardiothoracic surgeons can do for us. So it's called a metastasectomy. So it's basically, you can remove that lesion with either a wedge resection or you remove the whole lobe, depending on how big it is. The key components and characteristics is that you must have adequate lung capacity. So they will test your lung function, and obviously, hopefully, the patient doesn't have any other things going on in the lung like emphysema or COPD. And your cardiac surgeon can do this, usually recommended at a tertiary center where the cardiothoracic surgeon does many of these per year. And it's been shown to improve the overall survival. The second scenario that I talked about is the malignant pleural effusion. And sometimes, unfortunately, this is kind of the first scenario where we diagnose our patients with breast cancer. It's basically a buildup of fluid between the space of the lungs and the chest wall. And usually when you see that, the first procedure is a thoracentesis, remove the fluid from the lung and you examine the cells. If the fluid shows positive cytology, that's your diagnosis. And breast cancer is unfortunately the second most leading cause of malignant pleural effusion. And it's unfortunately, even though you don't see in the lung, when it's in the fluid, it's considered a stage 4 disease, unfortunately. So when you look in a chest or X-ray, you basically see a complete whiteout of that side. And that's kind of the first diagnostic tool that we use along with CT scans. So what are our treatment options for this? So we're focusing on, obviously, symptom management. Obviously, when you see a patient with malignant pleural effusion, we immediately obviously put them on systemic chemotherapy, but sometimes the chemotherapy doesn't work fast enough, and we want the symptoms to be resolved faster. So obviously one is doing a thoracentesis and doing it therapeutically. When the patient has shortness of breath, we repeat removal of the fluid. Another option is that if the fluid reaccumulates too fast, sometimes I've seen patients reaccumulate their fluid in about 2 to 3 days, an option is putting a pleurics catheter in there where it's a permanent catheter and the patient can drain that on their own. The third option is a VATS or with pleurodesis. So VATS stands for video-assisted thoracoscopic surgery, where the cardiothoracic surgeon or the pulmonologist puts a camera into the lung and basically seals off that space so that the fluid cannot reaccumulate. Again, all of these are done from a symptomatic area, and all the patients would obviously benefit while they're on systemic chemotherapy. So I'm sure some patients here have had this done, and we usually do it with an ultrasound now, and we basically put a needle into the cavity and use a vacuum suction to remove the fluid. Especially safe nowadays. We used to do it blind when I was a resident, but now we have ultrasound technology, and it's usually done by an interventional radiologist. Some complications can include a pneumothorax, which is quite rare nowadays since we're using ultrasound, but the lung is like a balloon, so if you put a needle in there into a balloon, and there's a chance where you can pop it and the lung can collapse. But we've avoided that now with the ultrasound guide thoracentesis. Also, if you think about it, the lung is a soft tissue, and if it's being drowned, it will shrivel up. So when you remove the fluid, the lung will try to re-expand. But upon re-expansion, it can also develop edema, and that can delay the recovery process of the patient. So those are things that we look for. So this is a picture of a thoracentesis, usually done by interventional radiologist. The needle is going into the pleural fluid and coming out. This is what I was talking about, the pleurics catheter. So you do this with a thoracentesis, you do the same procedure, but you leave a catheter with this little bulb-like appliance out at the same time, and the patient can drain their own fluid. The hope is that with systemic chemotherapy, the fluid will come down, and this is a temporary thing and can be removed. The last thing that I talked about is a VATS pleurodesis. It's a procedure, usually outpatient, and you can seal off that pleural space so that the fluid does not reoccur, and usually done with some talc powder or an antibiotic called doxycycline. Both techniques are used at the same time to prevent the reaccumulation. This is a little more invasive than your Pleurix catheter and is a little bit more painful, but you get a permanent resolution of symptoms. We talked about the second scenario is this pleural carcinomatosis and lymphangitic spread. This is where our patients are the most symptomatic, and unfortunately, you cannot radiate the lung at this point nor do surgery because the whole lung is studded with cancer. Unfortunately, systemic chemotherapy is the only solution at this point in time, and unfortunately, prognosis is poor. There's another scenario where we used to think that if there were other diseases, there would radiation help. Since we know that the primary source is the lung, would it help or hurt to radiate other areas where the disease has spread? And it showed that if you do some focused radiation to other areas, like for example, if the patient could not get surgery for that solitary lung lesion, you can focus some radiation to that area, and that's also shown some improving overall survival. Now the question is, sometimes as a medical oncologist, when a patient comes to me when they're complaining of cough and shortness of breath, I have to differentiate, is it A, the disease is getting worse? Is it B, something that I'm giving such as immunotherapy causing an inflammation in the lung? Or is it C, a form of interstitial lung disease, which certain chemotherapies we can, that can cause that we can give? So that's kind of the first kind of conundrum that we've been dealing with as a medical oncologist. Obviously, we do the CT scan, but sometimes a CT scan can't differentiate between these three. And I think our field is trying to differentiate these three things together. It would be bad for the patient if we thought it was progression disease and we would eliminate a form of therapy such as immunotherapy if we could actually reverse the pneumonitis with steroids. Other chemotherapies, such as this new one, trastuzumab deruxtecan, which is called Enhertu, this drug was basically approved 2 months ago by the FDA for third-line HER2 new positive disease, but there's a 3% chance that these patients get interstitial lung disease. So this is something that we deal with every day as a medical oncologist. This is the last slide. We have 4 trials with the group that I work with at LA Cancer Network and Breastlink. We can talk about, if you have questions, you can come up and talk about these, but we have the trials for metastatic triple-negative breast cancer. We also have the adjuvant study that's UCLA and us. We're the only 2 centers in Southern California that have, called the NATALEE trial, for patients who have advanced cancer but not metastatic cancer who could benefit from one of the drugs that we use in treatment earlier called ribociclib. These are my references, and I want to thank my colleagues at LA Cancer Network and Breastlink. Dr. Atiyah, who also helped me with some of these slides on the VATS and pleurodesis, who's one of the cardiothoracic surgeons that I work with, my patients, their families, and Susan G. Komen. Thank you so much.
Yeah, thank you so much, Dr. Tang, for that. That was very helpful. Hear about all the different treatment options and their varying success rates. Last up, we have Dr. Dayyani, and I'll let you tell us about liver and visceral metastasis.
Thank you so much. Good morning, everybody. So excited that you invited me this morning and giving me finally a reason to wear my pink shirt. Linda knows that's one of my favorite ones. So what we'll do in the next 10 minutes is really we don't have time to go into detail. What I want to tell you is what's available for when the cancer has spread to the liver. And then if there's more questions, then I will introduce you to my colleagues and our multidisciplinary tumor board where we can assess every single case on a case-to-case basis. So just briefly to put this into perspective, about half of patients with liver cancer whose tumor will spread to another site will have liver involvement. And if you look down here, about 12% or 1 in 8 patients will present with liver-only disease. So as you can imagine, this is a vital organ, and trying to contain the disease specifically in the liver is an important goal that we have in the treatment. No, I myself, I'm not a breast medical oncologist. I treat liver cancers, but it's the important thing for today is to know once you have advanced breast cancer, even to the liver, the first line of defense is systemic treatment, as all my colleagues already alluded to today. So depending on the makeup, genetic makeup or phenotypic makeup of your tumor, hormone therapy, chemotherapy, biologics, depending on what we just heard about, and obviously clinical trial, clinical trial, clinical trial. Linda is here from our breast research group, and we have a booth out there with what's available with my colleagues, Dr. Mehta and Parajuli and everybody else. So the first thing is to try to contain disease in the entire body using these systemic treatments. And then if what's left is liver disease, that's where we come in and try to clean up, right? So in the center of everything we do is the patient, obviously, and here represented by their loved ones and their support group. But when we make treatment decisions, this is the group that you don't see every Monday from 1 to 2 p.m. at UC Irvine, right? We have the medical oncologist, radiologist, the surgeon there, pathologist. Everybody needs to come together to identify the best treatment for that patient. So when we focus on liver-directed treatments, there's kind of two buckets that you can conceptually look at that. There are treatments that might lead to long-term remission. You know, before diagnosis, we don't use the C word, cancer. After diagnosis, we don't use the C word, cure, but really that's where we want to get you to, right? So we talk about long-term remission, being disease-free, no evidence of disease for a long time. And I'll briefly go through some of those modalities. And there are always cases where there's too much disease to cut it out or get rid of it. But you can contain the disease, you can shrink it, and you can delay progression. And all that results into improved survival or longer survival potentially. And those are the last two slides that I will talk about. So obviously, the first thing that comes to your mind, if a tumor is seen anywhere, in this case in the liver, let's go and cut it out. And that's what it looks at. The important part is if you look at the lower arrow, that's what you might see on a scan. But these smaller satellite lesions, they might be there, and they might be so small that you don't see them. That's why you don't take every single patient who has liver metastases to surgery and just cut it out. Because by the time they recover, new spots might pop up, right? So you have to make a multidisciplinary decision and make sure the right patient goes to surgery. Okay, so what are the outcomes? Well, there is no large randomized trials as we have with all the new drugs that are approved and will be approved. But if you look at the cohort of about 1,000 patients that underwent liver surgery, what you see here is about 60% were alive at about 3 years, 40% alive at 5 years. That's not at the time of diagnosis, but from the time of surgery. And when we talk about the second C word, that's what we refer to. What percent of them are actually cancer-free after the surgery? And in this cohort, about 18%, 1 in 5 patients roughly, were cancer-free 5 years after the surgery. So in the right setting, finding the right patient, this is obviously the go-to modality to get rid of what you see. And then you go back and look at these 1,000 patients and see which ones actually did well. These are so-called prognostic factors. And when we look at that, smaller tumors are better, less aggressive tumors are better. If there's no lymph nodes metastases, meaning the tumor hasn't spread anywhere else, it's better. If you cut it all out, that's a no-brainer. Liver only, that makes sense, right? If the tumor is in the lung and in other lymph nodes, why would you undergo liver surgery, right? Time from diagnosis, the longer it takes for the cancer to show itself, presumably the more slow-growing this cancer. And hormone-positive disease, which might be a surrogate for some of the other ones. Briefly, my other colleagues alluded to these. For patients who have maybe 1 or 2 spots, but they might not be a good surgical candidate. They might have other comorbidities, diabetes, stroke, whatever. They cannot go to surgery. For those, certainly stereotactic body irradiation therapy is an option. What it does is it combines accurate imaging with the patient position, and so you can give higher doses to the tumor and spare the rest of the organ, which is important. What is it? If you go back and look at the available data, smaller tumors at risky locations or patients who are not good candidates for surgery, about 4 centimeters, that's about where the best outcomes are in the retrospectives. It's technically challenging. You have to do it at a place with high volumes. You have to actually go in and put in what we call fiduciaries, these markers, so they know where to point the radiation to. But if you look at the series, about 1 in 4 patients who underwent SBRT in the right setting had local control. What does local control mean? That means if I treat this tumor, there's a 25% chance this tumor is done. It might pop up somewhere else, but that's not local control. So again, if you find a patient that has only these 2 spots and you radiate them, that's a 1 in 4 chance they're still in remission at 2 years. Good. Optimal dosing and patient selection for breast cancer has to be obviously evaluated. That's still a work in progress. The other modality where you can get long-term remission is what we call thermal ablation. You basically take small tumors and you either heat them up to burn them or you freeze them. Just very quickly, you put in a probe, and as you can see, if the tumor is too grow, you can't reach the entire tumor to burn it, right? And terms you might have heard, radiofrequency ablation. You use radiofrequency to heat up the tissue to kill it. Microwave ablation, that's a self-explanatory electromagnetic waves to produce, or you do what you might have heard, cryoablation. That's the opposite. You freeze the tumors to death, right? But that's really for small tumors, maybe an inch or smaller, and those might respond very well. If you compare radiofrequency ablation with surgery, one of the benefits is that you don't have to cut anybody open, so the first 3 months there is less mortality with ablation than surgery. 2% might be a little bit high, actually. These are older series. There is a size limit for ablation because you can't expand your field of heating up, so you can cut out larger tumors. Local failure means you cut it out for surgery. It's 0. It can't come back at that spot because that spot doesn't exist anymore. Ablation fails in up to half of the patients, and you would have to do something else after that. And again, it makes sense if there's nothing outside of the liver. Smaller, better. You see a theme coming through here. Complete response. Patients who are treated and those tumors completely die off, they do better than the ones where only maybe half of the tumor is dead. And again, hormone-positive tumors. The last couple of slides, what happens for patients who have too many tumors or can't go to surgery, or they have tumors outside of the liver but still need liver control because that's the vital organ. Here we use the concept that the normal liver gets its blood supply from the portal vein, you see it in blue, but the tumor is fed by the hepatic or liver artery, 95%. So you can go directly into the liver artery and do whatever you want, and you can, by and large, spare most of the healthy liver tissue. So that gives you an advantage in the local treatment. The two big concepts here are transarterial, and they're all arterial because you go through the hepatic artery because you want to reach the tumor. Embolization or radioembolization. Radioembolization is basically internal radiation to the tumor, okay? What are the differences? Really, it's the size of the particles. What you see here is, on the left, it's a tumor where you go in with very small particles, you see, and they reach the tumors because the vessels are small, but the particles are also smart. And on the right side, that's embolization. You give bigger beads that go and get at some point stuck earlier before they reach the tumor. But what do? What they do is they shut off the blood supply to the tumor. That's embolization. Now, you can just cut off the blood supply. That's bland embolization. You can put a little bit of chemo on top of these beads so they radiate. Or you can actually give chemo first into the tumor and then shut off the blood supply. We don't know if one is better than the other one. But again, if you have too many tumors, too many places, you can't go and shut off the blood supply to the entire liver. What you can do is go and shower the artery that you're targeting with radioactive, tiny radioactive molecules. We use them, we call them Y90, yttrium-90. And they go and shower, and basically, as you can see here, it lights up, internally radiate the tumors. Embolization, as we talked about, is you can give chemo or not. It's mainly used in primary liver cancer, but obviously that might be a palliative option for breast cancer. Minimally invasive, short hospital stay, usually only overnight. We are generating more data for breast cancer liver disease. You can't use it for all sizes or a number of tumor. That depends on the physician who treats you, but maybe 4 or 5 lesions, not more. Tumor shrinkage seen in up to 35%. Transarterial chemoembolization has fewer limitations, right? It delivers these small microspheres to the arterial blood supply. It involves some preparation. You have to go and do some mapping and find where the blood vessels are. This is really rare if you do it correctly to make sure the beads don't go outside of the liver. It's indicated for treatment of colon cancer, but there is a good number of data or retrospective series for patients specifically with breast cancer, liver metastases for radioembolization. Obviously, it works well if there's nothing outside of the liver because you only treat the liver. So to bring this to an end, in carefully selected patients with breast cancer, liver metastases, liver-directed treatment not only can palliate but also improve survival. As you see in selected series, up to 20-25% of patients were disease-free 2 to 5 years after surgery or RFA. Really, you have to first see how the tumor is behaving, start with systemic treatment, and then if nothing else develops, then you can go after the liver, right? We need more studies to find the best timing and the best modality for his patient, and that brings us multidisciplinary clinic. You need a group that brings in different specialties to make the best decision. In terms of what gives you long-term survival, potentially surgery, ablation, and SBRT radiation, and transembolization, radioembolization, certainly for more advanced disease, for disease control. I'll stop here and happy to take questions. Thank you.
Great. All right, well, thank you, Dr. Dayyani, and all the rest of our panelists as well for those wonderful presentations. Please, Dr. Soloff, join us. 3 questions? Okay. Looks like we have time for about 3 questions for our panel discussion, but of course, as you know, during the lunch break, you're more than welcome to come and ask as many questions as you like to our panelists. But in the meantime, if you have a question, please raise your hand. Our microphone volunteers will come find you. Share your name and tell us your question and who you want to ask it to, and try and keep it of general interest to our audience. You can ask more specific questions afterwards. And those of you who are on our live stream, we can also answer some of your questions if there's time. So who wants to ask our first question?
Let me ask the first question.
There she is.
I'm going to take over here. I didn't hear a lot about the importance of the lymph system in dealing with metastatic breast cancer. Is the lymph system not as important as we thought it was, and the bloodstream more important when we think about establishment of metastatic disease?
Do you want to ask that to anyone in particular, or
Dr.
should they?
Soloff?
Okay, it's you. We should have them all jump for it.
Yeah, thank you. So I will preface in that I'm not a medical oncologist, and as far as the treatment, I'm well behind what should be done than these gentlemen. In my opinion, it absolutely is. So lymphatics are a conduit, so they are part and parcel with the bloodstream. They're another systemic route of transmission. I didn't talk about it much. There is some work in the analogous processes hold true in lymphatics as do in the blood. There's actually some great work by an investigator, Amanda Lund in Oregon, who's looking at that type stuff. She's fantastic. You should check her out. So no, the lymphatics are equally important. They are an alternate route compared to the systemic circulation that should not be ignored. Yeah, so I didn't mean to leave them out. They just aren't big into what we are doing currently.
Any comments to add from anyone? We can move on to our next. Yeah, please.
No, I mean, right. So the treatment strategy is prolonging life as well as alleviating symptoms. So obviously, when dealing with bone-only tumor or with respect to recurrence to the chest wall or recurrence to the lymph nodes, the goal is always symptom management. So, edema and, pain associated with the lymph nodes, it's important to prioritize in terms of, symptom management.
All right, who wants to ask our second? Oh, do we have one more
I'll just
comment?
add, within the brain, until about maybe 3 years ago, we didn't even think the brain had a lymphatic system. So this is still a area that is ripe for research in the brain.
We have a question over here.
I think this, for Dr. Smith, if you've already had, let's say when you were diagnosed, you had bone fractures, and then you go on to, I'm not on Zometa, I'm on Xgeva. What is the percentage of reoccurrence of fractures? I mean, is there any statistics for that?
That's a great question. So if you've had one fracture in your lifetime, what is the risk of having a subsequent fracture? I've seen data put in anywhere from 20% or more. So it depends, I think, really on the nature of the fracture, where the fracture location was, but certainly, and of course, the life expectancy of the patient. But I've seen data ranging from 20 to 50%.
Ouch. Okay, you take care of yourself, Jennifer.
Another question? She's coming.
For Dr. Smith also. I've been on Xgeva for quite a while. I'm a 12-year survivor, and I developed ONJ and wanted to stop the Xgeva against everyone's advice. Is there enough of a danger in stopping in the risk of fractures to make me continue?
So that's a good question. So osteonecrosis of the jaw, again, that complication from Xgeva. The question is, if a patient develops it, what do? Do you give them a holiday? Do you continue them on the Xgeva? And I'm not certain that we have a solid answer for that. And so we do individualize. And I would say that if I were concerned enough about the risk of a subsequent pathologic fracture relating to the first question, I would feel more strongly about maintaining a patient on the medicine while treating. And the same holds true if a patient who's on it, who's going to undergo a dental procedure. Do we stop it? Do we continue it? We don't have a solid sense of what to do.
One more question. Here in the...
Thank you. Hi, my name is Chris. I was diagnosed with MBC less than a year ago, and it metastasized to my liver only. My question is for any or all of the panelists, and it's about survival time. We saw earlier in the presentation that the average 5-year survival rate is low, between 20 to 30%, yet we saw a number of women stand up and say that they've survived 10, 20 years, so that's great. I would like to get a little bit more information about drilling down into that average, that 20 to 30% average. And my question is sort of a two-parter. First of all, do we know if their survival rates differ depending on to which organ the cancer has metastasized? And then secondly, are there any other variables that we know that are strongly associated with or can predict longer survival rates?
If you were in my clinic, I would tell you the only question you will ask is, are these people who are alive at 5 years, yes or no? If the answer is yes, I don't care if it's 1% or 99, because there's a path to where. Why am I saying you that? Because all the data you see, right, to have a 5-year survival outcome, you have to follow patients for at least 5 years. Otherwise, you don't know what they're going to do, right? How many new drugs have been approved in the last 5 years for metastatic breast cancer? Pathways we never even knew that are going to be targetable. So what you see is historic data that has no bearing or very little bearing, right? That includes the prognostic factors. Obviously, very aggressive disease. If a tumor doesn't shrink to treatment, that's bad, right? But anything after that, it all depends on what new drugs are coming, how long are you going to respond, right? As long as the tumor does not grow, you will sit there with whatever you have right now, right? And if it starts and the tumor responds to the next treatment, so I really don't understand that question if you had come to my clinic, right? Because everything, unless you have a disease like Lou Gehrig disease, You guys know that, ALS? There's nothing for it. Maybe some supportive care. So there you have a very good idea about what's the average, how long we'll be at, because you just described the disease course. I would very much like to think that with metastatic breast cancer, you're changing the disease course. So the question is not what's the 5-year survival, the question is, are there people who are alive? And the answer is yes. And then you just have to decide, do you want to be in that pool? And then you find the best team for that. I know that's not the answer you want, but that's the real answer.
Any other comments?
I completely agree with it. As we talked about, I mean, these drugs are coming out fast and furious, and even we're approving these drugs even faster and faster. I mean, the Enhertu, the drug came out, that was off of phase 2 clinical data. We're not even waiting for phase 3. So a lot of these orphan drugs are coming out. So again, it's called historical data for a reason. A lot of these women did not have the benefit of getting a lot of these drugs. And that's why we encourage as a team that once lines have been exhausted, we really, really want to focus on clinical trials so that you can use tomorrow's drugs today, and history will be history. Yeah.
I think that's a really good point, and it's an important, for all of you that are here, being educated and knowing what is coming, I think is going to help you a lot also to improve your own, chances of better outcomes. Okay, well, thank you all so much for this discussion and for the great questions. That was really very... So now we're going to take a nice little break. We're going to have a nice lunch. Looks very wonderful. The lunches are on both sides of the room. There are also tables actually on each side of the room, which basically have very specific little conversation subjects located on them. So if you want to network and meet people and discuss specific topics, take a look to see what the topics are on those tables on the edges of the room. Also, if you requested a special meal on your registration, there are a couple of places where you can get those. So vegan and vegetarian meals are over there by the air wall. And gluten-free only meals are basically available on the back table. There we go. And also on the buffets, there are gluten-free options as well. So please enjoy your lunch. Hopefully you'll get some good discussions. And please don't forget to visit the expo area, the Pfizer booth, and talk to some folks out in the hallway. And we'll see you guys again, looks like 105. Okay, great. Thank you all so much.